After looking at the studies, would 2 doctors choose to use PRP injection? Check first and vote early and often. Okay, so Dr. Mark Vaughan and Dr. Gwen Vaughan here, 2 family practice physicians who actually do injection procedures for joint pains. And
we do.
Currently, what is our standard, Dr. Gwen?
We do steroid injections here.
That's kind of the standard that we got from our training and are still carrying on, but that could change.
Yep.
We want to be with the newest and the most evidence-supported ways of treating patients, and so that's why we look to see what that might be. And it really looked as if prolotherapy was superior or non-inferior, sometimes the way they put
That's sometimes how they put it.
to what we currently do, the steroid shots. A little more reading on it.
In some joints.
And it looks like there's more to it than that.
There always is.
That it has to do with the timing.
Sure.
That early on, the steroids are superior.
Yeah.
But you go like 6 months to a year after the injection, the prolotherapy is superior.
When do you want your relief?
Yeah. When?
It probably also depends on how severe that arthritis is. We do find that some things work better in more advanced arthritis. And there actually is kind of this curve where you get this benefit and then it starts to fall off, actually. So that happens for steroids. For steroids, if you're in that moderate to moderate.
So, I guess I'll go ahead and bring that up now. When looking at these studies, the thing that keeps coming out is such variability within the literature for how they're done, and the difficulty for people performing the studies where they bring lots of research trials together or a meta-analysis, and they find out that, this one found that wasn't effective, but this one used a different technique and it was effective, so does it work?
Replication.
For any one given thing.
What we run into with a lot of scientific studies, can we replicate that?
And it seems like it's more difficult with a newer therapy that's being introduced to the world of therapeutic medicine. In this case, we're talking about, in this show, PRP, or platelet-rich plasma. Mm-hmm. And you did such a great summary of what it was last time.
Yeah.
I've been practicing to say centrifugation. Which is the process of putting somebody's blood into a test tube.
Yep.
Except it's not for testing purpose. Putting it in a centrifuge, running it.
Spinning it.
That is centrifugation. It's fun to say. And then you get, you said you suck out the portion of it
top of it, because all the red blood cells go to the bottom.
Right. You don't want the red blood cells at the bottom, but you also don't want just plasma. You want that platelet-rich plasma, which is
that middle,
just sitting right above the red part, not the buffy coat. Remember the buffy coat?
Oh man, you're going back to.
So there's a little white line.
I do remember.
When you spin these down, you've got red. That's your red blood cells. You got the buffy coat. That's your white blood cells, and it's a thin line. And then right above that is platelet-rich plasma.
And they talk a little bit when they talk about PRP about leukocyte-rich and leukocyte-poor PRP.
Yes.
And this gets into, I'm just saying, this gets into like some say, it's better if it's leukocyte-rich versus leukocyte-poor. I mean, this is getting into specifics that are probably having to do with some of those white leukocytes or white blood cells within the blood. So
people doing studies
pull those
with that.
up. Where do you pull up that medication, that plasma from? Yeah.
So I'll just throw in why they think this would be helpful. The reason it's helpful is because so-called activated platelets release a bunch of growth factors, and I'm not going to go through the whole list of the different growth factors that are released. Just know it's a lot of growth factors that are thought to help to reduce inflammation, promote healing. And the idea is you get all of these released by using that platelet-rich plasma and injecting it right to the problem where the inflammation is located. Mm-hmm. And so that's the proposed mechanism.
Yeah.
There are lots of things in medicine where we have a proposed mechanism that we think should do something. And then you do the studies.
Theoretically, we think,
in the real world, in a real body, and you find out, oh my goodness, it's such a complicated system. What we thought the model was doesn't actually work out for the benefit we were hoping. Mm-hmm. And that may or may not be the case for PRP.
Yep.
It's been tested. It's been tested in a lot of places. It's been tested in shoulders. It's been tested
in joints.
in
tendons.
Hips. and variable results. Not to say it's not helpful in some things, but it's just not clearly great for everything, which people like things simple. People like things that they can tell their friend, hey, PRP works wonders, get it done for anything.
Yes.
That hurts. That's just not what the literature is showing.
Are you saying we're not going to be able to get a 5-second soundbite out of this and put it on social media?
That's the definitive statement.
Yeah. As with everything,
I wish.
it's more complicated than that.
Yeah, I'm sorry. So it looks like it may be beneficial for some things using some techniques, and we don't know what that is without diving even deeper into the literature, which we've looked. We've mostly through open evidence because it kind of references all the major journals, and we're looking at journals. Some of them are the New England Journal of Medicine, some are the Journal of the American Medical Association, some of them are Journal of Arthroscopy or North American Journal of Arthroscopy, which is joint pain scoping. So I'll show you on the browser here. So let's just do a simple prompt like compare PRP to cortisone shot for rotator cuff tear, hip osteoarthritis, that's the regular wear and tear arthritis, knee osteoarthritis, and tennis elbow. And just, the most basic summary of statements comes up first in bold there, and I'll even highlight it here so you can see what it says. Corticosteroid injections provide superior short-term relief, while platelet-rich plasma, or PRP, offers better medium to long-term outcomes. Now, that is a very
general statement.
Very, very general, basic statement that precedes pages of
getting
details.
Into nuance.
So let's actually give you some details.
Start out with rotator cuff. Yeah,
we'll start with rotator cuff tear. Rotator cuff tear.
That's fun to say.
A common problem in the shoulder that we give steroid injections for. And it says that the steroids demonstrate superior short-term functional improvement, like the first couple of months. And PRP provides significantly better medium-term, 2 to 6 months, and long-term, 6 months or greater, including improved ASES scores, constant Merley scores, and SST scores. And that's according to, they gather that data from 3 different journals, including the Journal of Orthopedic Research, the Journal of Shoulder and Elbow Surgery, and the Journal of Arthroscopic and Related Surgery. Oh, also, there's another journal here, Journal of Shoulder and Elbow Surgery. So those sound like journals. I don't know them, but they sound like journals that a particular specialty is going to use. Even within that specialty, though, we don't know, without being more familiar with it, whether these are actually truly really highly respected journals that have an editorial board that is very careful about what gets published, or if it's one of those, hey, send us $5,000 with your submission and we'll make sure it gets published.
Yeah.
And we're not on the editorial boards of them, so we really can't.
Partly why we have journal clubs, why we review these, why we scrutinize these different studies to make sure not all studies are created equal.
Yes, and so we're just doing a very, very broad look, as we as family physicians would do in the clinic when we're with patients.
Try to advise our patients
and
on
want to go, okay,
what to choose.
What would be here and now the best for you? So there's a couple things we consider. One is how good it is. Mm-hmm. Apparently, it's different between short and long term.
Yeah. What the patient's looking for,
And side effects or dangers or risks.
Absolutely. Yep.
Yeah. Okay, let's move on to another one. So that was shoulder. It looks like the PRP may actually be better in the longer term. Okay, I'll go ahead and say it now. This is what we're going to find with knee too. Knee osteoarthritis.
Right.
PRP may be better in the long term.
And even though it says that, like the journal I trust is the AAFP. That's the journal, the American Academy of Family Physicians. And in theirs, specifically when it comes to rotator cuff, they say, it's the data is just not sufficient. It's much better for the knees and for specifically rotator cuff, tennis elbow. So even though it says that, there's within my specialty, within our specialty, family practice, it's not recommended for shoulders. They still say that you should stick with with steroids for shoulders, for
I
rotator
am
cuff.
curious to know if do commercial insurances
cover
PRP?
That would be good to know too.
And if so, for what?
Yeah,
Because that's the thought that's coming to my mind here, thinking, okay, we may need to,
and you need to keep
go to
bringing
an
that into
educational conference and learn these techniques if they truly are superior,
right.
and bring them to our patients.
And you do have to have the cost benefit analysis in that too, right?
We show what we're looking at here as far as the whole. So most commercial insurances don't, and why don't they?
The data.
Probably because the data's not there yet.
Yep.
So you can have, there's degrees of how good.
Yeah, insurances are
performs.
they have all these actuary tables, and
Yeah.
they know these studies too, and there is a reason, theirs is again a cost benefit analysis as well, and that on the benefit, they need to have very good data showing that benefit if they're going to pay for it.
So we should use the example of knee replacement surgery for arthritis.
Sure.
Very
works.
drastic. Cutting the ends of somebody's femur and tibia off and putting metal pieces in for an artificial joint and then sewing them back up.
Well, you make it sound so.
It's
drastic.
that's a drastic thing to do. Borders on barbaric until you
And it's covered by insurance.
until you look at the end result and my
It
goodness,
actually works really well.
Grandma can walk again pain-free. That's a big deal. That's what that operation will do, as barbaric as it is, and as much as we want to avoid doing that kind of mayhem to a human's body.
Sure.
If you've ever seen a video of actual real orthopedic joint replacement,
It's traumatic.
it's not for the faint of heart to watch or stomach.
Yeah.
So that sounds like something we'd want to avoid. But yet, you see these people able, and you hear their testimonies of, hey, since I got my knee
woke
replaced,
up,
I
the
can
pain
walk
was
without
gone.
pain.
Yeah.
So the insurance companies compare that pain relief for years after the operation with how much relief somebody
10,
gets
15 years. Yeah.
from PRP injections. And amazingly, they actually think the PRP is not as cost effective at pain relief as a $20,000 operation.
Yeah, that's just amazing. Still not covered, even when we're comparing it to that.
We're not saying it doesn't do anything.
Right.
It's a matter of how much is it doing, how much benefit are you getting for what you're going through.
Right.
I still think we probably need to be very open to
doing that.
a future of where we would be doing that.
In certain joints where it shows, the data shows that it is. So knees is one where there is a benefit. And the AFP says that it recommends it for that.
Yeah.
But again,
it calls it off-label because it's not FDA approved.
Right, yeah, because it's not FDA approved. Insurances won't cover it. Yeah. So again, you have to have that conversation with your doctor about the cost versus the benefit of that. How long am I going to get this relief for?
Yes.
However much that may be, hundreds to thousands of dollars.
And we preach it too. Follow the money. We will have the, what do you call those, conspiracy theorists? We will have the conspiracy theorists or just people asking thoughtful questions. Say, okay, FDA, that's had a lot of people from industry on it in the past. That's been a criticism of it. And very much so within the last year that we've heard that said. And the answer seems to be, you could think that, and it does look like there'd be a mechanism for that. Remember, we talked about possible mechanisms. But if the evidence was stronger, if we saw a better benefit, if we saw a better lasting benefit to the PRP compared against things like placebo and steroid injection or the joint replacement, we'd be saying something different. The evidence just isn't strong enough. Mm-hmm. That's why we're in the situation we're in. And people are getting their knees operated on, which we'd rather not do. But it looks like it's the effective way to have a person go on for years,
right,
not having the pain.
Right.
Okay. Next joint. What's the next joint going to be?
Lateral epicondylitis. We're going to talk about a non-joint.
Okay.
Tennis elbow.
Let me get over there. So I'm going to skip the.
So tennis elbow is over the outside of your elbow, right here.
Yep.
Where
from the backhand.
From the backhand of tennis, and people almost never come in saying I was playing
wrist
tennis.
Extension and Also supination too, right?
Rotating.
So supination is this. I'm holding a bowl of soup. Supination versus pronation.
Motions of the
Yes.
of the wrist and forearm.
Thank you for saying wrist and forearm, because I don't like it when people say it's all in the wrist. No, this joint is moving too. Look, see it? See that movement? You can feel it all the way from the elbow to the wrist.
Yep.
And look at that. It stays in the same place, but it's turning.
Yeah, because
Whereas
rotating
this
around
bone is going all the way from here to here. It's going from there to there, even though it's in the same place here. One turns over the other. It's,
Nice little anatomy lesson on the.
And here it is. 4, lateral epicondylitis corticosteroid injections provide excellent short-term relief. 92% success at 6 rates. That's an incredible rate for an injection we give in the office. But result in substantially worse long-term outcomes. So this is
when it's compared.
This is cortisone shot we're talking about here.
This is a comparison too.
So,
not just worse outcomes by itself.
Compared to physical therapy, 91%.
I like that it says watchful waiting too.
Or watchful,
just
doing
nothing. Nothing at all.
is nearly as effective. 83%.
Long term. Yeah.
83%. More than 4 out of 5 patients. Watchful waiting, doing nothing,
You're going to get better.
gets them better.
People don't like hearing that.
Oh, they hate it when they're hurting.
Yeah.
Especially when you're pushing on their elbow.
Give me an injection.
Give me the shot.
That's the conversation that needs to be had. Well, you'll get better initially, but it may get worse actually in the long term.
83%. Physical therapy, 91%.
Yeah, physical therapy is great. Big fan.
For PRP and tennis elbow remains mixed.
Oh,
For some reason, those researchers can't all get the same
Figure it out,
answer.
guys.
And then we can go here at this little summary for tennis elbow.
Corticosteroids.
CS provides excellent relief. What's CS? Corticosteroids. Thank you.
Yeah.
Whereas the PRP, mixed evidence, no clear superiority. Corticosteroid associated with worse outcomes. What? 69% success. PRP shows no consistent benefit over CS or saline, just a placebo. Corticosteroids may impair long-term healing. PRP evidence inconsistent. So it actually kind of sounds to me like we shouldn't be doing the cortisone shots for tennis elbow.
Pretty rarely do them, yeah. Yeah.
And if we were to do the PRP...
Physical therapy is the thing to do.
We'd actually be...
Out on a limb there.
Not making it worse.
We wouldn't be making you worse.
Evidence inconsistent. Mixed evidence, no clear superiority. So it looks like to me, for tennis elbow, we're not going to be doing either one of these. Did we have a different outcome with prolotherapy last week? I think we did.
We did, I believe so.
I think it looked like
that was...
But, you know, we only went halfway with prolotherapy last week. When you dig deeper...
It's a deep dive, yeah.
It really looks like there's a lot of variability and not super clear answers.
Yeah.
Yeah.
And this is kind of consistent with where you look as well, because even within the medical community, you can get differing opinions depending on what recommending authority you look at, which is very frustrating because we should be consistent across all specialties in this, and we're not.
Yeah. We move to hip?
Let's move to hip.
Okay. Robust head-to-head comparisons between PRP and corticosteroids are lacking. For hip osteoarthritis.
The first part of that sounded like it was going to be but then it says are lacking.
I'll do prolotherapy for the hip. PRP for the hip, I would also say no, because you'd think that by now they'd at least have some studies that were poor, rather than having it just hardly anything to even review.
So I think that true title of this should be Why We Are Luddites When It Comes to Hip Injections.
Well, no, we aren't for sending them to ortho for their...
We don't do those injections. You got to get deep into the joint to really get a good effective...
Well, you have to be in the joint.
Yeah.
How do you find it?
Which is deep. That needs to be like usually guided by imaging.
You need guidance. Yeah, you need an ultrasound right there on it. You need to see where you're going.
And we don't.
Yeah.
Okay. Into that.
So, conclusion.
Conclusion.
So, here we go. PRP
for
shoulder. Yes or no?
Am I going to do it? It said better for short term.
No, long term.
Sorry, long term, but not as good for short term.
Yeah.
The problem is with shoulder, people want the short term relief. Like they're not willing to wait, so it's tough.
Yeah.
I don't think I'd jump on board and do it, especially since it's going to be paying cash for this. I think I'd try conventional means first, what that insurance would cover.
We do know that long-term results are worse because of the steroid.
Yeah.
Platelet-rich plasma is safer. We'll probably continue to do the steroid injections unless there's data showing something different.
Physical therapy.
Yeah.
It always kind of goes back to that.
Yes.
You should always be doing physical therapy on these types of things.
That actually would be my highest recommendation.
That can
keep
help
needles out of it.
Significantly.
Yeah.
Yes.
Okay. And it's amazing. The way the anatomy is in the shoulder, if you can get through physical therapy, I wish I had better visuals for this.
Oh, yeah.
So the shoulder is a
ball and socket.
Ball and socket. And the inside of the socket up here, you've got this thing that's over time, this is arthritis, the process of arthritis, it's growing down into the joint. And right here where the ball hits the socket, that's where the tendon is on the top.
Right over.
And so
it's
every
like
time you
all four
move
of those rotator cuff tendons
those
go
tendons
right
are
over.
grinding against this bony growth that's coming down. And so when they do the arthroscopy, that's what they shave off. And arthroscopy is very effective for that. But physical therapy in many, many, many patients, if you do it and you strengthen the right muscles, you can actually get that ball part of the ball and socket to sit lower. So it's not always rubbing against it. And that's why when they have you do the resistance bands like this, or like this, or like this, or like this, pulling down to your sides, they tell you, while you're doing the exercise, keep your shoulder blades together, bring them together, and keep your shoulders down. And that way you're using those muscles that pull that down and keep it from rubbing against that bony spur. That's why physical therapy done long enough will actually get people better results than these shots without having to, risk of infection, a needle. And if you can get your doctor to give you the physical therapy exercises by your own bands, it costs less than going to the physical therapist. We do usually like to have somebody who really knows physical therapy, that being the therapist.
Yeah. More effective that way.
Have people come back, make sure they're still doing the exercise with the correct technique. But I have greatly reduced the number of patients that I send to physical therapy.
And just do it home.
And I have open evidence help me with the exercises or get them actually straight out of Epic, and I'll tell which ones.
They have their little
tell them
after
get their own
visit
resistance
summaries.
bands, and if they want me to check how they're doing them, I'll look at it.
Sure.
But that's one little thing that we refer to physical therapy that I'm doing less of and saving patients, actually saving them a lot of money.
It can be a lot, especially if you have a high deductible plan where you're on the hook for the first thousands of dollars.
There are some physical therapy offices in this town that cost a lot.
It can add up quickly because you're going twice a week for 4 to 6 weeks. So
okay, that was a good show on platelet-rich plasma, or PRP. Thank you, Dr.
Yeah.
And so we still have to talk about, you remember what was next of those 3 injections that we tried to do in one show?
We had to split up. I don't know, what was the third one?
Stem cells.
Oh, stem cell, that's right.
So
I guess that's
unless
next.
some kind of news in health and medicine preempts us, that's probably what we'll be doing next time.
Hey, I'm Dr. Glenn.
Dr. Mark Vaughan telling you to stay in good health.